Welcome to the deep dive. Today we are scrapping in for, well, one of the most anatomically demanding journeys in neurosurgery. We're focusing on that central neurological crossroads, where the brainstem basically meets the spinal cord. Accessing this area, it demands precision, measured really in millimeters, and a deep, deep understanding of just a staggering density of bone, muscle, nerve structures. It's intense.
It really is. That crossroads, that's the foramen magnum, the FM, and the bit right above it, the inferior clivus. You can think of it like a funnel, right?
Yeah.
A choke point for the brainstem itself. Major vessels like the vertebral artery, those lower cranial nerves, everything vital passes through. So to really get a handle on the surgical pathways here, we need to go way beyond the basics. Our deep dive today, it's built on the foundational knowledge you'd find in the big surgical anatomy texts, specifically looking at material based on Drader's surgical anatomy, which means we're getting into the real details, analyzing the gold standard procedures. We're talking about the complex far-lateral approach for dorsal access.
Coming from the back.
Exactly. And then the newer cutting-edge endoscopic endonasal approach, the EEA, coming in from the front, ventrally.
Right. So that's our mission today. We're going to unpack this locoregional anatomy, the bone, the muscle, the neurovascular stuff so thoroughly that you, listening, hopefully gain a real shortcut to being fluent in the surgical thinking behind these approaches. Think of it as the essential distilled knowledge you need for, well, true professional mastery in this area. We're going to take the time needed to really get the why behind every single technical step.
Okay, let's unpack this critical anatomy. Okay, so when you're dealing with lesions around the FM, the foramen magnum, and that inferior clivus, the first big decision is the direction of attack, right? Ventral from the front or dorsal from the back.
That's the fundamental choice. And historically, well, dorsal approaches are very common. Often they start as variations of the, let's say, simpler posterior suboccipital approach.
The kind you might use for something like a Chiari malformation decompression. Exactly that sort of thing. But the far-lateral approach, that's a significant step up. Much more complex. It demands exposure much, much further out laterally from the midline.
And that sounds like it requires absolute orientation right from the get-go.
Oh, absolutely. Before a scalpel even touches the skin for a far-lateral, the surgeon is hunting for key surface landmarks. And the C1 transverse process, the C1TP, is arguably the most reliable, really the non-negotiable initial landmark you need to find.
Why is the C1TP so critical at this very first stage? What makes it the star?
Well, it's all about its relationship to the, let's call it the high-risk zone deep down. You can often feel it, palpate it right next to the mastoid process. And that proximity, that gives the surgeon an excellent external reference point that translates directly to where you'll be working deep inside. Identifying the C1TP is absolutely instrumental because it helps you anticipate and then later definitively locate the V3 segment of the vertebral artery, the VA, during that initial muscle dissection.
Okay. So it's like the compass needle pointing straight to the biggest danger.
Precisely. It points towards that primary neurovascular hazard.
Got it. Okay, let's talk indications then and how the procedure is staged. The basic far-lateral approach. What's it typically used for?
So the basic version is really tailored for accessing lesions along the posterior or maybe posterolateral aspects of the foramen magnum. Classic targets would be things like meningiomas in that location, or maybe specific nerve sheath tumors.
And what defines the basic approach, anatomically speaking? How is it different from the more extended versions?
The basic approach, it generally involves a suboccipital craniotomy, so removing bone at the back of the skull, combined with taking off part or all of the C1 lamina, that's a C1 hemi or complete laminectomy. But the critical anatomical differentiator, the thing that makes it basic, is that it's done without removing any part of the occipital condyle, the OC.
Okay, so you get the lateral view you need, but you don't compromise the joint stability there.
Exactly. It gives you that necessary lateral corridor without messing with the occipitocervical joint's integrity.
Now, patient positioning. You mentioned this requires constant midline reference, and the sources talk about a modified park bench or a three-quarter prone position. That sounds tricky.
It is tricky, precisely because of that tilt you need. This position, it maximizes the surgeon's working angle way out lateral to the mastoid process. It lets gravity gently pull the cerebellum out of the way a bit. But like you said, it brings in a significant practical hazard. You can lose your sense of where the true midline is. Positional disorientation.
Because the patient's rotated.
Exactly. You're operating with the patient turned, and it's easy to misjudge the true midline. And if you misjudge that midline, well, your trajectory for removing bone is going to be off. You risk hitting the sigmoid sinus, that big vein, or just missing the optimal angle down to the foramen magnum altogether. So maintaining your reference points, constantly checking against the inion, that bump on the back of the skull, and the spinal midline, that's just non-negotiable throughout the whole muscle and bone dissection.
That constant double-checking of the midline sounds absolutely fundamental for safety.
Yeah.
Okay, let's move more superficially then.
Okay.
The incision itself. We read about inverted U-shapes, horseshoes, lazy S incisions.
Yeah.
What's the goal behind these different shapes?
Well, the shape is mostly chosen to allow maximum mobility of the skin and the muscle flaps you create. Get them out of the way easily. Specifically, the ability to extend the medial and lateral limbs of that incision downwards inferiorly. That's paramount.
And why extend downwards? What does that achieve?
It serves two key purposes. First, it just makes it easier to do the surgical laminectomy, exposing C1 and sometimes C2 if needed. And second, it gives you really wide visualization of where those deep muscles attach around the C1 transverse process. It lets you confirm that critical landmark visually before you commit to the deeper dissection.
So the whole initial surgical window is built around needing to see those deep bone markers clearly. The critical palpable landmarks need identification and marking right at the start, the mastoid tip, the inion that's your absolute midline marker, and of course the C1 transverse process.
Exactly. And that marking process, it actually goes deeper than just the skin markings. You'd have to sort of project mentally and sometimes with markers the location of the major venous structures underneath. A key deeper marker to map out is the transverse sigmoid junction, the TS junction.
Where the transverse sinus turns into the sigmoid sinus.
Precisely. That junction sits right under the bone you're about to remove, laterally and superiorly. So its location is marked out using a kind of triangulation from external landmarks, the mastoid tip, the top of the ear, the auricle or pinna, and the zygomatic arch, the cheekbone. If your incision doesn't go high enough, say above the inion, you just won't get enough exposure for the occipital bone removal you need up there. It limits your access to that TS junction area, which really defines the upper limit of your bony removal. So this preoperative planning, using these external markers to locate internal vascular structures, that's really the very first step toward avoiding a potentially catastrophic venous bleed later on.
Okay, this feels like where the real deep mastery of the far-lateral approach begins. Because as you hinted, it's not just one single procedure, it's more like a spectrum, right? Defined by how far towards the front, ventrally, the pathology forces the surgeon to go, and therefore which specific bone gets sacrificed. And this spectrum, it ranges from, let's say, conservative to really quite aggressive, and each step up seems to carry a much higher risk-reward trade-off.
That's perfectly put. That decision matrix, exactly how much bone to remove, that's the absolute essence of surgical judgment in this tricky area. We really have to differentiate between three main defined extensions, ways of pushing beyond that basic far-lateral approach we talked about.
All right, let's break them down. Let's start with the least aggressive extension, the paracondylar exposure. What does that involve?
Okay, paracondylar exposure. This becomes necessary when the pathology, the tumor or whatever it is, just slightly nudges up against the jugular foramen area. What it involves is drilling the jugular process of the occipital bone. That's the little bony bit where the rectus capitis lateralis muscle attaches. The goal here is to get access to the posterior or maybe posterior-inferior part of the jugular foramen, the JF, and the jugular bulb itself, that collection point for venous blood. Often this is done along with a mastoidectomy component, but crucially, the occipital condyle, the OC itself, it's preserved entirely in this maneuver. You don't touch the joint surface.
So it just gives you a little bit more visualization laterally and maybe slightly superiorly without messing up the head-neck stability.
Exactly, just a sliver more room without sacrificing that crucial axial stability.
Okay. The next step up takes us into, well, genuinely risky territory, the transcondylar exposure. Here, we're actually removing the posterior part of the occipital condyle itself. Why is removing part of this critical load-bearing bone justified? What's the payoff?
The surgical payoff is significant. It's about vastly improved access and, importantly, visualization. Removing that posterior part of the condyle creates a much wider, straighter working corridor down to the lower clivus and the area immediately in front of or anterior to the medulla oblongata. This is where really challenging lesions often sit, things like anterior foramen, magnum meningiomas, or maybe extensions of chordomas. This shift in trajectory from posterolateral to a more direct lateral to ventral path, it's often indispensable if the pathology is mainly sitting ventrally.
And this is where that very specific safety limit comes in, the one everyone talks about. You can only remove the posterior third of the condyle. Why that exact fraction of the posterior third? What's magical about that?
It's not magic. It's pure anatomical safety. This is a critical safety zone, and it's basically a non-negotiable rule in neurosurgery. Remember, the occipital condyle articulates with C1, the atlas bone. It bears the weight of the head. The anterior two-thirds of that condyle, those are the primary load-bearing surfaces. That's where the joint works. But maybe even more importantly, the hypoglossal canal, the HC, runs directly through those anterior two-thirds of the condyle.
Ah, the tunnel for the hypoglossal nerve.
Exactly, cranial nerve at 12. So if you drill past that posterior third marker, you inevitably breach the hypoglossal canal. And that risks not only direct damage to the hypoglossal nerve itself, but also, and this is critical, catastrophic occipitocervical instability. The joint just won't work properly anymore. Breaching that threshold, going beyond the posterior third, it basically mandates a full occipitocervical fusion procedure afterwards. You have to stabilize the joint surgically. The whole operation shifts from just a craniotomy to remove a lesion to a major stability procedure as well.
Wow. That connection, removing just a few extra millimeters of bone, meaning the patient now needs a full fusion, a massive increase in morbidity that really highlights the surgical trade-off, doesn't it?
Yeah.
Okay, so let's push it to the limit now. The most aggressive option, the supracondylar transtubercular exposure. This sounds like the nuclear option for dorsal access.
It pretty much is the maximal dorsal exposure you can get. This approach is reserved for lesions that are highly ventral, sitting right on the front of the brainstem, and maybe also extending superiorly. Cases where you need the absolute widest possible working angle directly onto the anterior brainstem. Often this is about getting superior visualization of maybe the basilar artery or critically the origin of the PSC, the posterior inferior cerebellar artery. This approach intentionally violates that safety zone we just discussed for the transcondylar approach. It first involves drilling the hypoglossal canal itself.
So you deliberately sacrifice the HC.
You sacrifice the HC deliberately, yes. And then after that, you proceed to drill the jugular tubercle as well.
Okay, so the surgical goal has to justify that cost, that neurological risk, and the definite instability.
Precisely. For example, if you need to clip a PICA aneurysm, particularly one that's tucked way down ventrally and maybe superiorly, close to where the PICA comes off the vertebral artery, this maximal exposure might be the only way to see it safely. It provides really unparalleled visualization of that PICA origin from the VA.
Let's focus in on these key bony structures then, the ones that define these different procedures. First, the hypoglossal canal, the HC. When we look at its structure, the books say it runs in an anterolateral direction. What's actually passing through this tiny but critical tunnel besides cranial nerve 12?
Yeah, the HC is actually a pretty crowded space. It contains the hypoglossal nerve, of course, but it also has a complex venous plexus surrounding the nerve, think tiny veins packed in there, and also the meningeal branch of the ascending pharyngeal artery runs through it too. Now, when the surgeon is doing a transcondylar approach and drilling just that posterior third of the condyle, they're essentially just skimming the lateral edge of the intracranial opening of the HC. Knowing that the canal runs anterolaterally, that knowledge guides the angle of the drill. It helps ensure you avoid injuring the nerve along its length, unless, of course, you've deliberately chosen the transtubercular approach where you intend to drill it.
Right. And what about the jugular tubercle, the JT? You mentioned earlier it acts like a shell for the lower cranial nerves.
That's a good way to think of it. The JT is this distinct, quite dense bony prominence located superior and slightly anterior to the hypoglossal canal. It's like an architectural feature, a protective little shelf made of bone. The lower cranial nerves, that's IX, glossopharyngeal, X, vagus, and XI, accessory, they are literally draped over this tubercle as they run towards their exit point, the jugular foramen, JF. So when you perform that maximal transtubercular approach, you are deliberately removing this bony shelf. The goal is to effectively drop those nerves slightly out of your direct line of sight, maximizing the working corridor straight towards the anterior brainstem pathology.
That makes the jugular foramen itself incredibly complex too, being the exit point for all those nerves and major veins. It's described as having distinct compartments. How does that affect drilling nearby?
Correct. The JF isn't just a simple round hole. It has structure. The inferior petrosal sinus, another venous channel, drains into the smaller anterior compartment of the JF. Then the much larger sigmoid sinus, SS, drains into the robust posterior part. This forms the jugular bulb, which can be quite prominent. And sandwiched right in the middle, in the intermediate compartment, that's where you find those critical lower cranial nerves, I, X, and Evely. Understanding this tripartite structure is vital. It guides the safe limits of any bone removal you do superiorly in this area. The surgeon has to be absolutely meticulous to avoid breaching that jugular bulb during any bony work.
Okay, let's transition now from the hard stuff, the bone, to the intricate soft tissue work. The muscular dissection for the far-lateral approach is often described as maybe the most challenging initial stage. It sounds like it demands careful, layered reflection rather than just sort of bulk dissection, especially to protect nerves and vessels.
Oh, absolutely. While, you don't necessarily have to individually dissect and name every single tiny muscle for the procedure to work, understanding the distinct layers is absolutely crucial for preserving key vessels. The most superficial layer, the first one you encounter, includes big muscles like the trapezius, the splenius capitis, and the sternocleidomastoid. Once you reflect those, you get down to the second layer. This consists of the semispinalis capitis and the longissimus capitis.
And it's within this second layer, right, that we run into a bit of an anatomical curiosity, the occipital artery, the OA. Why is its specific position noted in relation to the longissimus capitis muscle?
Good question. It's noted because the OA has somewhat variable anatomy. It can lie either superficial to the longissimus capitis or sometimes it runs deep to it. Now, while preserving any artery is generally good practice, its exact location needs to be confirmed, either preoperatively with imaging or definitely during the surgery. Why? Because the occipital artery is a vital potential conduit.
A conduit for what?
For bypass surgery, if the patient down the line might need some kind of complex vascular reconstruction, maybe an ECIC bypass for blood flow issues, the OA is often a preferred donor vessel because it's right there in the field and usually a good size. So knowing its exact course determines how aggressively you can mobilize and maybe cut the muscular attachments in that area without accidentally sacrificing this potentially crucial artery.
Got it. Okay, so once that second muscle layer is managed, the next critical target is exposed. The suboccipital triangle, often just called the SOT, you called it a surgeon's terror earlier. This really sounds like the high hazard zone for the far lateral approach. Let's define its boundaries precisely.
Okay, the SOT. Yes, it's an anatomist's delight because it's so neat, but a surgeon's terror because of what's inside. It's defined by three muscular boundaries. The superior oblique muscle, SO, forms the top border. The inferior oblique muscle, IO, forms the bottom border. And the rectus capitis posterior major muscle, RCPM, defines the medial border. And the floor of this triangle isn't muscle. It's actually the posterior atlanto-occipital membrane, a tough fibrous layer.
And nestled inside this small triangle lies the primary non-bony risk, the V3 segment of the vertebral artery.
That V3 segment is the absolute critical structure here. It's the part of the vertebral artery that runs from the little hole in the C2 vertebra, the foramen transversarium, and then it takes this looping course around the C1 arch before it finally pierces the dura to go inside the skull. Running right alongside it, and often just slightly inferior to the VA, is the C1 dorsal nerve root. And crucially, encasing both of these delicate structures is the highly susceptible vertebral venous plexus. Lots of veins packed around the artery.
When you say susceptible, what are the practical consequences if, say, that venous plexus gets torn, or maybe one of the VA's small muscular branches gets injured during dissection?
The consequences are immediate, and they can really interrupt the flow of the surgery. We're talking severe, often pulsatile bleeding. The venous plexus, even though it's relatively low pressure compared to the artery, is really expansive. It can be incredibly challenging to control quickly if you inadvertently tear it while reflecting the muscles. This can lead to significant blood loss right at the start, and it obscures your vision just when you need it most before you even start the bone work. This is exactly why those V3 protection techniques like carefully exposing the C1 hemilamina, starting medially and working your way out laterally until you definitively feel the C1 TP are so meticulously practiced. It's all about finding the artery safely.
Okay, so as the exposure gets deeper, the inferior oblique muscle, the IO, which forms the bottom of that triangle, is retracted downwards. What critical relationship does this maneuver reveal about the V3 segment's course?
Retracting the IO muscle inferiorly is key. It allows the surgeon to clearly see that V3 segment running along its characteristic J-shaped groove, which is literally carved into the posterior arch of the atlas of C1. And this reveals the crucial relationship you need to burn into your memory. The VA always passes medial to the atlanto-occipital joint just before it pierces the dura.
Medial to the joint between the skull and C1.
Exactly. Understanding that the artery passes medial to that joint line ensures the surgeon knows the absolute lateral limit for removing the C1 arch, while also protecting the joint itself from accidental damage.
Okay, and we established earlier that the occipital condyle itself sits lateral to the anterior half of the foramen magnum. So this all confirms the trajectory needed. Now let's talk about finishing the extradural bony work for the basic far lateral. What are the key milestones or landmarks that tell the surgeon, okay, the basic...
Right. The craniotomy, the bone window in the occiput, needs to extend superiorly up to a point called the asterion, which is near that TS junction we mentioned. And laterally, it needs to go right up to the edge of the sigmoid sinus SS. You definitely don't want the bony removal crossing the midline, obviously, to avoid the contralateral sinus and the other vertebral artery. But the final, really critical venous landmark that often signals the basic extradural exposure is complete is the identification of the posterior condylar vein, PCV.
The PCV, that's one of those emissary veins, right? Connecting inside to outside. How does it function as a landmark here?
Exactly. It's an emissary vein. It connects that vertebral venous plexus, the one we said surrounds the VA in the suboccipital triangle, directly to the sigmoid sinus, that major venous channel running laterally in your field. Identifying the PCV is a pretty reliable anatomical marker. It signifies you've reached the transition point between these two important venous systems. It confirms that you've achieved the required lateral extent of the basic far lateral exposure specifically, the exposure that stays posterior to the jugular bulb region.
Okay, so the bone work's done, the sigmoid sinus is identified and protected. Now the dura, the covering of the brain and spinal cord, is opened, usually in a J shape, extend down immediately towards the foramen magnum. But the text emphasized leaving a cuff of dura around the vertebral artery's entry point. Why is it so important to maintain that little dural cuff right there?
That cuff provides absolutely essential protection for the artery at a very vulnerable point. Firstly, it prevents excessive manipulation of the V4 segment of the VA, that's the part just inside the dura, during the subsequent tumor or lesion reception. And secondly, it significantly minimizes the risk of a cerebrospinal fluid, a CSF, leak right at the dural entry point. Those specific leaks can be notoriously difficult to repair effectively in this particular location. So leaving that cuff is a key step for safety. And that really completes the pathway for dorsal access. Okay, now we need to completely flip our perspective. Do a 180-degree turn in our anatomical thinking, moving from the posterior, the dorsal approach, to the ventral one coming from the front. Historically, the main way to get ventral access was the transoral route going through the mouth.
Right, opening the back of the throat.
Exactly, but that route, well, it was associated with pretty high risks of infection because you're traversing the contaminated oral cavity. It could also cause significant dental morbidity, issues with swallowing and speech post-op, and honestly, the upward visualization looking up towards the clivus was often quite limited. This is precisely why the endoscopic endonasal approach, the EEA, going through the nose, has largely replaced it for many lesions in this area.
Yeah, the EEA seems revolutionary in this context. It provides such a direct, straight-line path, and it's minimally invasive, right, to the inferior clivus and the anterior part of the foramen magnum. And the big advantage seems to be minimizing neurovascular manipulation, because you're often approaching the lesion from the exact direction it's already pushing the brainstem.
That's the core philosophy. The procedure itself follows a very meticulous, systematic rostrocaudal progression, basically, working from top to bottom through the nasal passages and sphenoid sinus. The very initial step is actually structural. You need to flatten the midline maxillary crest, which is the bony ridge overlying the hard palate at the back of the nasal floor. This maneuver creates the foundational, wide enough corridor you need to actually proceed backwards towards the clivus.
Okay, so once that initial corridor is established, the surgeon then has to deal with the layers of muscle and fascia covering the front of the clivus and upper spine. Which specific muscle layers need to be removed?
You need to remove the soft tissues overlying the anterior vertebral muscle group. Specifically, that means identifying and removing parts of the longus capitis muscles, the rectus capitis anterior muscles, and also incising the median pharyngeal raphe, which is the midline fibrous band where muscles attach. Taking down these layers exposes the bare ventral bony surface of the inferior clivus, which is now ready for drilling.
And what are the defined bony boundaries for this endonasal exposure? How does the surgeon know they've drilled far enough up, down, and out to the sides?
The exposure is very strictly defined by landmarks visible through the endoscope. Rostrally, meaning superiorly, the limit is the floor of the sphenoid sinus. You don't want to go into the sinus itself unless necessary for the pathology. Caudally or inferiorly, the exposure typically extends down to the superior aspect of the anterior arch of C1, the atlas bone. So that central box you've created, IS, the inferior clivus. Laterally is where the access gets more complex and tailored. Superolaterally, the exposure can extend towards the lower edge of the foramen lacerum, near the carotid artery canal. And inferolaterally, it extends out across the front part of the occipital condyles and the atlanto-occipital joints, potentially on both sides if needed.
Now, if the pathology, the tumor, is sitting a bit off to the side or maybe extends higher up laterally, that initial central drilling of the clivus probably isn't going to be enough, right? The surgeon needs to push that exposure wider laterally. Which brings us, I guess, to the EEA's own version of condyle removal.
Exactly right. That initial central clival drilling provides the midline access. But to widen it laterally, the surgeon performs what's called a medial condylectomy, endonasally. This involves drilling away the medialmost portion of the occipital condyle from the front. Functionally, you can think of it as being analogous to that posteromedially directed condylectomy we talked about in the far-lateral approach, but obviously performed from the completely opposite direction. Doing this radically improves the working angle out towards the lateral aspects of the lower clivus and the craniocervical junction.
So even from the front, the bony structure of that lateral exposure is still fundamentally governed by the hypoglossal canal.
Absolutely. The HC remains the key landmark. The dense cortical bone lining the hypoglossal canal acts as the main lateral dividing line visible endonasally. If you're drilling inferior to the canal, you're in the condylar compartment. If you drill superior to it, you're working in the jugular tubercular compartment, just like from the back. And depending on how low the pathology extends, further maneuvers to maximize access might include drilling the superior aspect of the anterior arch of C1, or even drilling the tip of the odontoid process, the dens of C2. This really transforms the opening from just a clival window into a full cervicomedullary exposure all through the nose.
Amazing. Okay, so once all that ventral bony work is done and the door is open from the front, exposing the premedullary cistern to the space in front of the medulla, we face those key ventral neurovascular relationships. What are the major vessels you see immediately?
Right there in front of you, you'll typically see the V4 segment of the vertebral artery, often both sides converging. You'll also see the anterior spinal artery, the ASA, which is absolutely critical for perfusion of the spinal cord and lower brainstem. And depending on the level, you'll see the origin or proximal segment of the PICA as well. But honestly, the single most important safety concept in the entire ventral approach revolves around understanding the precise spatial relationship between the vertebral artery, the C1 ventral nerve rootlets, and the hypoglossal nerve, CN12.
Okay, let's really pause and focus on this triad, because this relationship, I gather, is often counterintuitive and absolutely must be memorized for safety when working ventrally. What is the precise relative arrangement?
Okay. In the ventral view, looking from the front with the endoscope, the hypoglossal nerve, CN12, which you can sometimes see emerging from the preolivary sulcus of the medulla, lies posterior to the vertebral artery. It's behind the VA from this perspective. Conversely, the C1 ventral rootlets are positioned anterior to the vertebral artery. They lie in front of the VA. This is the absolutely vital rule you have to internalize. 12 is posterior, C1 is anterior, and they effectively sandwich the vertebral artery between them. You absolutely have to understand this relationship to safely dissect lesions, like chordomas, for example, which often wrap themselves around their vertebral artery. If you're operating endonasally and you clearly see nerve rootlets anterior to the vertebral artery, you know those must be C1 rootlets, and therefore you know that cranial nerve 12 is hidden behind the artery from your current viewpoint.
Wow. So the VA itself becomes the absolute centerpiece landmark, the structure that definitively tells you where those two essential nerves are located relative to it. And where does the PICA, the posterior inferior cerebellar artery, fit into this already complex triad?
Ah, the PCA. Well, it makes things even more complex, naturally. The PPA typically travels posteromedially after arising from the VA. And very often, it actually weaves right through the rootlets of the hypoglossal nerve, CN12, on its way back towards the cerebellum medullary fissure. Now, imagine an anterior foramen magnum meningioma. It might push this entire complex, the VA, CN12, with the PPA looping through it and the C1 rootlets significantly posteriorly. This makes that initial dural opening and positive identification phase incredibly risky. You have to know exactly what you're looking at. Mastering this relationship, C1 anterior, 12 posterior, VA in the middle, PICA weaving through 12, that is truly the cornerstone of safe ventral navigation at the craniocervical junction.
Okay, we have meticulously mapped the complex anatomy of both the dorsal and ventral approaches. Now let's try to synthesize all this detail into the kind of practical knowledge that really differentiates, a competent surgeon from a true master in this area. Let's nail down the definitive hazard checklist and the absolute key anatomical takeaways.
All right. Starting with the dorsal approach, the far-lateral, the primary anatomical hazard, without a doubt, is vertebral artery, VA, protection. We have to minimize the risk of injuring it at all costs. That means achieving that proper layered muscle reflection to clearly identify the suboccipital triangle, the SOT. And critically, always exposing the C1 hemilamina starting from the medial side and carefully working laterally until the C1-TP is definitively palpated and ideally visualized. Those specific steps are protective because they locate the artery before it can be accidentally snagged or damaged by the drill or a bone-cutting instrument like a rongeur.
Makes sense. And then the most significant bony hazard, as we discussed, relates directly to stability of the condylar resection.
Yes. That rule over the posterior third, it's basically sacrosanct. Removing more than that posterior third of the occipital condyle is really an unacceptable risk in most situations because it virtually guarantees you will breach the hypoglossal canal. And breaching the HC inevitably leads to occipitocervical instability, which then necessitates an immediate surgical fusion. This isn't just a potential complication you might mitigate. It's a fundamental structural failure you've created.
Right. And in those more advanced dorsal approaches, like the transtubercular, drilling near the jugular tubercle itself also requires extreme caution, doesn't it?
Absolutely. Drilling the tubercle to widen that corridor for a transtubercular approach carries the immediate and very real risk of either direct mechanical injury or thermal injury from the drill heat to the lower cranial nerves IX, X, and XI. Remember, they are sitting right on that bony shelf just before they dive into the jugular foramen. These nerves control critical functions like swallowing and voice production. Injuring them results in severe, often permanent long-term morbidity for the patient. So extreme care is needed there.
Okay, let's try to distill the core anatomical knowledge down into, say, 3 absolutely essential checklist items for mastery. First, you mentioned the boundaries and contents of the suboccipital triangle, SOT.
Yes. You must know those 3 defining muscles: superior oblique, inferior oblique, rectus capitis posterior major. And you must know that the V3 segment of a VA, along with the C1 root and the venous plexus, is nestled right inside it. Furthermore, understanding the potential variability of the occipital artery's location relative to the longissimus capitis is important, recognizing its potential role in future bypass procedures.
Okay, checklist item 2. The preoperative bony identification markers essential for the dorsal approach.
Right. Before the craniotomy even begins, you must identify and fully understand the surgical relevance of the asterion, the inion, the mastoid tip, the C1 transverse process, the posterior arch of the atlas C1, the occipital condyle itself, and the atlanto-occipital joint line. These are the fixed geographical points of your entire procedure back there. You have to know where they are.
And third, those 2 absolutely crucial spatial relationships we hammered home: one dorsal, one ventral.
Exactly. Dorsally, the key safety check during bone removal near the joint is knowing that the VA dural entry point is always situated medial to the atlanto-occipital joint line. And ventrally, for the endoscopic endonasal approach, the non-negotiable relationship you must know cold is that Van Nerve triad. The C1 ventral rootlets are anterior to the VA, and the hypoglossal nerve, CNN12, is posterior to the VA. Memorizing and constantly applying these relationships is your final safety shield when you're working right on the surface of the brainstem.
This incredibly detailed anatomical map, this is what allows the surgeon to even attempt the resection in the first place. But what happens when the anatomy is perfectly navigated, the resection seems successful, yet the patient still suffers a severe negative outcome? Let's bring in the clinical reality check with that case study mentioned in the source material, the 36-year-old female patient with a Foramen Magnum meningioma.
All right, this is a really instructive case. This patient presented with a fairly large contrast-enhancing lesion right at the foramen magnum. Looked exactly like a meningioma on imaging. And it was causing significant compression and distortion of the lower medulla oblongata. Very dangerous spot. Because of the position of the lesion, which was mainly posterolateral, the surgical team quite reasonably opted for a basic far-lateral craniectomy combined with a C1 hemilaminectomy. And the surgical effort itself technically was a success. The tumor, which turned out to be a benign WHO grade 1 meningioma, was resected completely. They minimized manipulation of the brainstem, they protected all the surrounding structures, applying exactly the anatomical principles we've just spent all this time detailing.
Okay, so textbook anatomical success achieved. The tumor is out, structures preserved. But the patient's postoperative course, this really highlights the critical difference between technical anatomical mastery and the total functional outcome for the patient, right? What actually happened post-op?
Initially, right after surgery, the patient was neurologically stable. Looked good, but subsequently she developed quite severe left-sided hemiparesis. Weakness, almost paralysis down her left side. Now, crucially, this deficit occurred not because of any direct mechanical injury during the resection itself. The surgery was clean. Instead, it happened in the setting of postoperative hypotension. Her blood pressure dropped too low, and also suspected vasospasm, where the arteries might have clamped down. The thinking is that the medulla oblongata, having been critically compressed by that tumor for a prolonged period, had lost its ability to autoregulate its own blood flow. It became acutely sensitive to any drop in systemic blood pressure. So even a seemingly minor physiological shift downwards in her blood pressure was enough to compromise perfusion to that incredibly sensitive brainstem tissue.
Wow. That is a really profound lesson in the sort of physiological fragility of the brainstem, especially after it's been compressed. The anatomical navigation was flawless, but the functional result was severely compromised purely by hemodynamics, by blood flow issues. How was the situation reversed? Did she recover?
Thankfully, yes. The clinical team correctly identified the likely issue: inadequate perfusion pressure. So they initiated aggressive medical management focused specifically on blood pressure augmentation. They used medications to deliberately induce hypertension to raise her blood pressure. The goal was to artificially force more blood flow, raise the perfusion pressure to that exquisitely sensitive, recently decompressed brainstem tissue. And the response was dramatic. Her neurological deficits, which included near paralysis of her left leg, began to improve almost immediately after her blood pressure was raised. Within about 2 weeks, her severe deficits had improved significantly, back up to grade 4 out of 5 strength. This clearly demonstrated that the underlying anatomical integrity of the pathways was preserved during the surgery. The problem was purely one of acute physiological compromise.
Yeah, that case really encapsulates it perfectly, doesn't it? Why anatomical knowledge, while absolutely fundamental, is really only half the battle.
Mm.
You can successfully navigate the suboccipital triangle, protect the VA perfectly, avoid the hypoglossal canal, do everything right anatomically, and still potentially have a poor outcome if that delicate physiological environment, the perfusion, the pressure, the blood flow, isn't managed absolutely flawlessly, both during and especially after the surgery. It seems the brainstem just tolerates almost zero deviation from its optimal blood flow, particularly after it's been under chronic compression. Hashtag tag outro.
Exactly. And this entire deep dive, I think, really reinforces the immense stakes and the sheer complexity involved when operating right at this craniovertebral junction. Every single specific, detailed pathway we discussed, from knowing the limit of that posterior third of the condyle to the incredibly complex navigation of the C1-XIVA triad endonasally, every single step is a meticulously developed strategy. And it's all designed with one primary goal: to minimize irreversible risk to the brainstem itself and to the critical vessels and nerves that sustain it.
Yeah, we've definitely moved beyond just reciting definitions today. We've tried to understand the real clinical trade-offs involved, like why the occipital artery might be needed as a bypass reservoir later, why the jugular tubercle is only removed under the most extreme necessity due to the nerve risk, and how that 180-degree difference between dorsal and ventral access creates two entirely different sets of critical neurovascular relationships that surgeons simply have to master.
Indeed. And we know now, especially from that clinical case, that good neurological outcomes depend not just on the surgeon's technical ability to minimize mechanical manipulation, which is perhaps a key advantage of the EEA for some lesions, but just as critically, outcomes depend on ensuring perfect hemodynamic stability, managing that blood pressure and perfusion. That was the crucial lesson learned from that patient's post-operative course.
So, given that the line between anatomical success and functional recovery is clearly so incredibly fine, as that 36-year-old patient's case vividly demonstrated, let's leave you, our listeners, with this final, maybe provocative thought to consider. If we assume that the technical surgical technique itself is flawless, absolutely perfect anatomical execution, and the final outcome still rests heavily on managing that hypersensitive brainstem perfusion, then what critical roles do advanced preoperative imaging, things like high-resolution MRI, maybe diffusion tensor imaging to map tracks, and sophisticated real-time intraoperative monitoring, like using motor-evoked potentials, somatosensory-evoked potentials, what roles do these technologies play? Could they help us anticipate, maybe even chart, and actively mitigate that physiological risk before it leads to a deficit? Perhaps even before the dura is opened, something for you to mull over or maybe explore on your own.